Dear students, today we will discuss a topic which is very common. In day-to-day surgical practice, we will come across. And you need to know because it will be kept in the clinical exam, theory they will ask, MCQs, Viva, anywhere. Ulcer, examination part, we had enough lectures earlier. In the short lectures, you can always go through that. And management of ulcer. Very briefly, I will tell and detail. You can go through my manual of surgery and clinical methods in surgery. But this brief lecture is very, very useful. You can recapitulate, remember very compact way so that you can reproduce whatever required thing in ulcer in your exam of whatever variety. But on the backup, you have to read my SRB's manual of surgery, ulcer topic, and SRB's clinical methods in surgery, ulcer topic. So what is ulcer? Just go through the basic. What is ulcer? I'll just brief it before entering into the management aspect. All of you know, ulcer is discontinuity in the covering epithelium, lining epithelium, covering epithelium, whatever it is, due to cell or molecular death. Wound is disruption of tissue, any organ, any lining, whatever it is, a very gross terminology, functionally and anatomically or structurally. Whereas ulcer is basically in relation to the lining. There is a point which is very important. This lining, covering epithelium, that is a point which is very important. So parts of an ulcer, all of you know, margin, that is where it is runs across the edge from the floor to margin, where normal epithelium or lining begins. Floor is where it is seen actually. This is seen, floor is seen. Base is where ulcer rests. So base is not seen, base is felt. Whether it is fixed to, base is fixed to what? Bone, muscle, fascia, whatever. You have to assess by checking the mobility of the ulcer in two directions. Many chronic, long-standing large ulcers it may fix to the bone. And surrounding area is also important, whether it's pigmented, hyperpigmented, edematous, red, all those things, whether there is active features of active inflammation or not. So the surrounding area gives a fair idea about the what type of ulcer it is, how ulcer is progressing. All those things, information clinically it will give if you carefully look into the ulcer. Now, edge is very, very important. Often it is decisive also when you come into the clinical diagnosis. Different types of edges are there, which I am going to discuss later. So margin is which is seen from the edge, from the surrounding area, where apparently normal and diseased area. So margin is seen, margin is difficult to feel. Margin is explained or described clinically as well-defined or ill-defined, regular or irregular. Okay. So edge is defined, it is from the margin to the floor, so distant. So it may be punched out, it may be sloping, it may be undermined, it may be everted, it may be beaded. That point I will discuss later. So these are the different parts of ulcer: margin, floor, base, edge, surrounding area. Base is not seen, other things are seen. Base is only palpable. So this is the point which you have to remember. So this diagram is very, very important. So different edges, I told margin, regular, irregular, well-defined, ill-defined. Edge is different. It comes like this. So sloping edge, you can see that is a healing ulcer. It is a feature of healing ulcer. It's like this, like this. So red granulation tissue will be there. So got a red, blue, where new epithelium begins, and white, that is scar tissue or fibrosis forms. So inside the granulation tissue, epithelialization, epithelial proliferation, then scar. So red, blue, white is the component of the sloping edge. It is a feature of healing ulcer. Here, it is a feature of healing ulcer. Sloping edge is very crucial, this one. So red, blue, I told red, blue, I told white due to scar or fibrosis. So undermined edge, we can see that this one, undermined edge. See that in tuberculous ulcer like this. Tuberculous ulcer is typically undermined because disease, there is a simultaneously in the tuberculosis, a disease progression, trial healing occurs. So disease progresses faster in the deeper plane, porous like this, whereas skin is or epithelium is resistant for disease involvement compared to the deeper tissue. So it will be like this. So there is some amount of immunological cells are there. It gives resistance to disease progression in the lining. So it will be like this. So there's a reason why tuberculosis ulcer is under. It's very typical actually. Punctured out is a trophic ulcer like this. It is due to endarteritis. Usually it's very deep. Bone is usually the base. Usually it is immobile. Commonly seen as in bedsore, trophic ulcer, diabetic patient, spinal diseases, neuropathic patient in the limb. It may be diabetic, maybe peripheral neuropathy, maybe spinal disease, maybe spinal cord injury, maybe spinal fractures. So many conditions are there. So that is the typical of the, in syphilis also punctured ulcer is there, of course, because of the endarteritis. Whereas in trophic ulcer, it is because of nutrition and neuropathy, neurological problem. There is no neurological problem. In diabetic neuropathy, you know that you got a sensory neuropathy, no sensation. You got a motor neuropathy. So arches of the muscle is function is lot. You got 4 layers of muscle there with the arches, longitudinal arches, medial and lateral. All these arches are weak, muscles are weak, and so motor neuropathy develops, and autonomous neuropathy, whatever that skin turnover will be lost because of the autonomous neuropathy, and so it is punched out deep, and base is usually formed by the either deeper soft tissues or essentially bone, whatever in the deeper plane. So that is typical of the punctured out ulcer, trophic ulcer, bed sores are typical examples in a bedridden patient. And olden days, of course, syphilitic ulcer, now it is uncommon. And beaded ulcer, rodent ulcer is a ulcerative form of the basal cell carcinoma. You know that commonest malignant skin tumor is a basal cell carcinoma, and common in face it's a beaded, it may be pigmented. There are different types, superficial, morphea type, all those things. Nodular, ulcerative, ulceronodular. So many types, single, multiple, maybe there's many syndromes, but it never spread through the lymph node nor through the blood because of the size of the cells, which are larger than the size diameter of the lymphatic, fine lymphatic, micro lymphatics, and so it is difficult to enter through the lymphatics. But the base is squamous, it behaves like a squamous cell carcinoma with the nodal spread. So when it forms ulcer, it is beaded. Now, reason why it's a very slow growing tumor, but erodes into the deeper plane. This is called rodent ulcer. Rodent erodes, like that, same. So rodent ulcer. So beaded appearance is because some cells in the edge are active, and in between some cells are dormant, non-active. So wherever active cells are there, there is a proliferation, beads. No active cells, there will be dip. So alternatively it becomes like that and becomes bigger, goes deeper. So sometimes it erodes in the bone, soft tissues, in the face, it may go close to the eye, it may go to the eye, and so on. Destruction is a very common, deeper destruction is a very common entity in due course of time. If patient doesn't come for definitive surgical therapy or whatever the therapy as proposed. So that is the typical of the beaded edge, is the typical of the BCC, rodent ulcer. So another type of edge is everted edge. It's a carcinomatous ulcer like this. It is like this. If you put a water into the bucket fills up and flows like this, get everted. So everted edge like this. Very typical, everted edge is very typical of carcinoma ulcer, usually squamous cell carcinoma. Any other carcinoma also, if it is ulcerative form, it get everted. Maybe ulcerative, sometimes active proliferation becomes ulceroproliferative, or proliferative ulcer with the proliferation is proliferative ulcer, ulceroproliferative, ulcerative, ulceroproliferative, proliferative ulcer. Initially proliferation occurs, then forms ulcer. There is little meaning differences between each. Ulcerative, squamous cell carcinoma, ulceroproliferative, ulcer proliferates, proliferation, then ulcer form, proliferative ulcer. Finally, it is one and the same. It is a carcinomatous ulcer, eventually everted edge. So that is very typical of the everted edge. So this is the everted edge. So this diagram is very, very useful to understand different edges. Also gives very much clinical clue to give a proper clinical diagnosis. This is very, very important slide, remember. So different edges, I'll just go through the clinical look. See that this is a typical healing ulcer. Red, blue epithelium, scar tissue white. Red, blue, white. From the, it is sloping. It is like this, sloping, like this, sloping edge. So this is undermined tuberculosis. Here you can see that tuberculosis ulcer, like this it is, like this undermined edge, typical This is the punched out ulcer. See that? This is the punched out. See the bursar and trophic ulcer in the heel. Very common site, remember. Other site is heads of the metatarsal, not hand, heads of the metatarsals. So this is the typical beaded edge. Look at this. Typical beaded edge. Rodent ulcer. BCC, commonest malignant skin tumor. MCQ question, remember. So this is the typical proliferation ulcer. Carcinomatous ulcers. You can see the everted edge like this. Very typical look. Look at that. Very typical look. Everted edge. This is this one. So this is what explanations I already told. These pictures will give a clear clinical idea for you to diagnose in any given patient. So classification of ulcer: healing ulcer is a healing ulcer, non-healing ulcer. You can see that healing ulcer with all three components: sloping edge, red, blue, white. Non-healing ulcer, see that there is no sign of healing, no red granulation tissue, no there is slough is there. Slough is the dead soft tissue. Remember definition: in situ, dead soft tissue in situ. And no sign of healing at all. It's the typical non-healing ulcer. Spreading ulcer, it spreads actually. See that? It's a very active ulcer. See that is very active ulcer. It spreads. You can see the discharge there. Active destruction is there in the surrounding area. So that is the spreading ulcer. Almost it's a healing ulcer, but it is active ulcer spreading. So almost is not healing, non-healing ulcer. It's a non-healing ulcer, but active. That becomes spreading ulcer. Callus ulcer. See the callus ulcer here. Callus ulcer. Just check. See that? See the callus ulcer. It is callus ulcer, callous attitude of the patient and ulcer. There is no sign of healing at all. Absolutely no sign of healing in callus ulcer. See that? There is no intention to heal at all. There is the exact meaning of the callus. No sign of healing. It's a very chronic ulcer. So these are the 4 types of ulcer which you have to remember. This is exactly it looks like. So other classifications, just see acute ulcers and chronic ulcers. See that acute ulcers are ulcer heals usually within the 4 weeks. 4 weeks is a very apparent timing. Within the proposed time of healing, it heals. You expect this ulcer should heal in 4 weeks. It heals. So chronic ulcer is ulcer does not heal within the expected period of the healing. So that becomes chronic ulcer. So there is local healing is not there because of the etiology, localization, anatomic location, maybe over the joint, maybe over the feet, maybe other causes also because of the etiology as such. So this is not time bound actually, even though commonly we say 4 weeks. It's definition wise within the expected period of time. It is, if it is not healing, that is called, because expected period of healing will be different in each different locations and different etiology also. So that's why even though 4 weeks considered where arbitrarily it is considered as a 4 weeks, it is not actually into every ulcers. Each ulcer because of the anatomic location and etiology, the behavior differs. So we expect it to heal in certain period in that particular situation. So if it doesn't heal, then you call it as a chronic ulcer. So somebody can't just define whether on the time bound, but usually it is 4 weeks, but not necessarily always. So it is individualized. So pathological classification is again important. Specific ulcer, I already told, tuberculosis, syphilitic, actinomycosis, melanese ulcer. It is a postoperative synergetic ulcer, spreading ulcer, carcinomatodent, melanotic ulcers, most aggressive, remember. It's a locally malignant. This is loco-regionally spread to the lymph node unless patient is immunosuppressed. Non-specific ulcer, traumatic, mechanical, physical, chemical, arterial ulcer, atherosclerosis, venous ulcer, gravitational ulcer, venous ulcer, gravitational, post-diabetic, trophic ulcer, pressure sore, infective ulcer, tropical ulcer, Vincent bacteria, Fusiform bacteria, all those things are the tropical ulcer may occur in the face, leg, body, anywhere. Cryopathic ulcers are because of the low temperature, freezing temperature, or other things. Mortarless hypertensive ulcer occurs in the leg around the ankle, not in the foot actually, lower leg around the ankle. But pulse may be normal in this patient. Remember, Bayesian disease is commonly in the girls, young girls, in the leg, lower leg, again maybe related to the tuberculosis of the skin as such. Diabetic is very, very common, most common, rather very common in the feet. Cortisol also, you keep on applying cortisol in ointments, local applications, skin get thinned out, cells, immunological cells destructed, and it forms a chronic ulcer. So applying long-standing cortisol containing local applications may be difficult to he treat. Healing will be prevented. So only short-term use these things. Keep on applying this one unless clinicians or dermatologists prescribe and advise for certain specific conditions like so many dermatology conditions with immunological diseases and allergic diseases. You may have to apply cortisol ointment related ointments. Otherwise, per se on your own, don't apply long-term cortisol. It will cause the ulcer as such. So this is the another grading for classic ulcer, mainly used for the trophic ulcer and diabetic ulcers and other ulcers. Grade of pre-ulcerated healed ulcer, superficial ulcer deep to subdivision bone, abscess formation, osteomatis goes deep on. So from above downward it becomes worsen. This is fair, this is very severe. This is a fair situation, this is severe. Easy to treat, this one very, very difficult to treat and often land with the amputation. So as the grade increases, aggression increases. That is the exact meaning. And different discharges in ulcer are serous, healing ulcer, purulent or seropurulent infected ulcer. There are different types of Staphylococcus, yellowish and creamy, Streptococcus bloody and opalescent, Pseudomonas, this is very important, greenish. All this color may be asked as an MCQ question. Malignant ulcer, bloody or serosanguinous. Healthy relation tissue also will be bloody. Malignant ulcer again serosanguinous, serous with sulfur granulus, actinomycosis, very typical sulfur granulus. Actinomycosis is really a bacteria, which is fungal-like bacteria. Originally, initially classified as a fungus, but now it is considered as a bacteria. Ray fungus, it's a misnomer. Ray fungus, sun-ray appearance on staining. That is what it looks like. It is called as ray fungus. So it is not fungus. It is bacteria where you get this sulfur granules. Yellowish, tuberculosis is another bacterial infection. It can be yellowish. Remember. So ulcer examination, case sheet writing. I'll just put into this name, age, all the things are important. Chief complaint, put it in orderly way. And this slide, this table actually helps in this one, history, mode of onset, progression, duration, pain, fever, discharge, number of other symptoms, past history, final disease, trauma, all those etiological factors, personal history, especially smoking, alcohol, other habits, addictions. Family history also important. Some ulcers may be familiar. There's a 3-generation family, you have to ask history. General exam is very important. Anemia, hyperproteinemia, nutrition, edema, pulse, BP again important. Local is very important. Site of ulcer, size, shape, number, margin, edge, floor, discharge. Base is not seen. Base is palpable. Remember, surrounding area is important. Opposite side, always examine opposite side. Neighboring area, if required in the limb, examine, inspect in standing position. That is important. In a limb, inspect ulcer always in standing. Also inspect ulcer in standing position. That's more important. Otherwise, you may miss the varicose vein. Inspect all around. That's also important. All around. Palpation again, tenderness, temperature, size of the ulcer. Measure it, vertical and horizontal in centimeter. Caliper you can use, vernier caliper. Bleeding on touch, palpation of the floor, palpation of the edge for induration. You have to bleeding. You have to palpate, especially floor for bleeding, edge for induration. So induration is very, very important. Look for induration. It's a feature of carcinomatous ulcer. And chronic ulcer, induration may be present in a callus ulcer, chronic ulcer. So induration is very important. Induration is felt always in the base, edge, surrounding area, not in the margin, not in the floor. Base, edge, surrounding area, look for induration. It is a very hard feeling in these areas. Amounts for fibrosis or localization. It suggests carcinomatous ulcer, L-differentiated variety. And in chronic ulcer with the fibrosis, it becomes, there is induration may be there. Depth of the ulcer you can measure, often difficult. Mobility is very important. Always check in due direction. Relation to deeper structure, if it is in the muscle, contact that muscle and check the mobility again. Joint, again check the joint mobility, joint movement. So each adjacent joint movement also very important. Again, surrounding area, tenderness, bone thickening in the leg, lower leg, tibial thickening suggests periostitis, calcaneal thickening suggests periostitis. So bone thickening, run your finger like this, suggests periostitis. And in such a situation, X-ray should be taken, often MRI, because once if there is a periostitis, healing will be difficult. So that is a problem. It prevents the healing. Limb girth and length, especially in congenital conditions like gigantism, A malformations, girth and length, or some fracture, girth and width may be altered. So other examination joint is important, ankle joint movement, plantar flexion, dorsiflexion. Inversion, eversion is not by ankle joint movement, it is by subtalar joint. Don't get confused. Plantar flexion around 45 to 50 degree, 40 to 50, 45 degree dorsiflexion. Inversion, eversion. Inversion is around 15-20, eversion is around 15 degree. So that is subtalar joint. So don't get confused. Ankle joint and subtalar joint. Ankle joint only, plantar flexion, dorsiflexion. Inversion, eversion for the subtalar joint. Always commonly asked a Viva question or MCQ question. Don't get confused which joint to have the which movements. Regional lymph nodes, if it is in the leg, vertical group of lymph nodes. If it is in the upper limb, axillary lymph node. If it is around the head and neck region, neck lymph node should be examined. Examination standing for a varicose vein, I already told, very, very important. And if there are varicose veins, all those essential clinical tests with including Doppler has to be done. Brody-Tenlenberg test, modified Perthes test, and run your finger for the perforators, and Fagan's test, it is called Fagan's test, and different tests look for DVT. So all those tests has to be done in relation to the varicose vein. Peripheral pulse from below upward, not from the above downward, in a tabular form actually, right, left, dorsalis, posterior tibial, popliteal, femoral artery, radial, ulnar, brachial, subclavian, carotid, superficial temporal artery, right, left, present, absent. And over which bone you are palpating, you should know. You can always read my peripheral arterial examination in my clinical method in surgery and manner of surgery chapter. In that chapter, spine in dizziness is very, very important. Systemic examine abdomen, respiratory system, cardiac disease may be associated also. So this slide is very, very important. How to examine an ulcer in orderly fashion, including history taking. That is very important. So clinical diagnosis, investigations of an ulcer. So proper clinical diagnosis you have to give. Right foot, dorsal aspect, chronic non-healing ulcer due to diabetes. Like that, full diagnosis you have to give. Investigation, accordingly you have to do that. Routine investigation, HB is important because healing will be delayed. Albumin, HB less than 8 gram %, healing will not occur. Albumin less than 3 gram %, healing will not occur. Blood sugar is important in diabetic patient. Creatinine, if there is a chronic kidney disease in a diabetic patient, again healing will be hampered. Altered liver function, again healing will be a problem. So these are very important even though they are routine. Specific discharge study for culture sensitivity. Sometimes you have to do a tissue culture also to assess the quantitative component. If it is more than 10 to the 5 per gram of tissue, streptococcus, in such a situation, grafting cannot be done. So this way, sometimes this is the discharge study to say which bacteria and which bacteria and which antibiotic is sensitive. But quantitative analysis to decide for the grafting, you have to do you have to take a tissue and send for culture. When you take a tissue for culture, don't put it in the formalin, put it in the normal saline, or ask microbiologist how exactly you want to send, and it should be sent immediately because they want to do essential culture thing as early as possible to get a appropriate result outcome of the test as such. AB when you suspect tuberculosis, cytology when you suspect malignancy. So wedge biopsy from the edge. So it's not just edge biopsy. Wedge biopsy, you take, if ulcer is like that, you take wedge biopsy. So usually 1/3 from the ulcer, 2/3 margin you have to take. Ideally you are supposed to take from the diagonally, at least 2 biopsy, diagonally opposite side, 1, 2 minimum. So from the edge, not from the center, because center there may be necrosis, but certain situations you have to take from the center. One is post-radiotherapy recurrence, edge proliferation will not be there. Proliferation occurs, recurrent disease from the center. In such a situation, you have to take biopsy from the center. And in mainly that is the situation, syphilitic ulcer and other conditions may take from the center, but mainly recurrence disease, post-radiation recurrent disease, biopsy taken from the center. Otherwise, all biopsies are taken from the edge as such. So imaging X-ray has to be taken to see osteomyelitis, bone involvement, periostitis. MRI also has to be done in a selected patient, especially to identify the food complex, so abscess cavities, destruction, soft tissue, everything. If you want to assess and if you want to see that, you may have to do amputation or aggressive wound debridement. MRI is very essential. Vascular Doppler, whether it's arterial or venous, depending on the situation. Based on the clinical examination, you decide arterial or venous. Doppler with the B mode Doppler scan, that's important. B mode. B mode is brightness mode in all these Doppler. In other mode is motion mode. Motion mode is mainly used for echocardiography. Remember, MRI imaging is again in selected patient. CT angiogram, ultrasound abdomen, CT angiogram. In vascular problems, so we have to do CT angiogram to look for the blockage, stenosis, complete block, corkscrew appearance, distal runoff, collateral levels, everything you can see, and mainly dynamic CT angiogram. Conventional CT angiogram is done when you do a therapy. If you want to do a angioplasty, if you want to do, then you have to do a conventional angiogram. Other for dynamic CT angiogram is important. Ultrasound abdomen, so assess abdomen, chest X-ray if there's a tuberculosis, CT abdomen and chest. In such situations, if you want to confirm better assessment, then you have to do CT abdomen and angiogram. CT chest. Final diagnosis, clinical diagnosis different, final diagnosis, everything after evaluation. What exactly is patient? This is also important to plan the treatment. And so ulcer management is cost to be identified. It's very, very important. It is the cost, it's very important. So it should be identified by all this evaluation method. Clinical type should be identified. Healing ulcer, non-healing ulcer, callus, then another etiological type. Malignant ulcer, specific ulcer, non-specific ulcer, traumatic ulcer, hypertensive ulcer, venous ulcer, arterial ulcer, all those so many times which I have already told. So clinical, based on the clinical presentation, you can decide. Clinical test, very, very important. Nodal status is important, especially in malignancy and chronic disease. Systemic features, melanoma with the nodal, melanotic ulcer with the lymph node involvement. They may be having a liver enlargement, large liver, brain spreads, brain metastasis, or lungs by mets. So systemic features are important. Varicose vein, arterial plus adjacent joint sensation should be checked. Sensation is important, especially in spinal injury. Diabetic neuropathy, very common. Wound imaging, X-ray, Doppler, CT angiogram, discharge system, I have already told. Correction of anemia is very, very important. Hemoglobin, already told. Deficiencies, metal, all vitamin deficiency, heavy metal deficiencies, essential element deficiencies should be supplemented. Protein supplement is very, very important. There is a protein deficiency, healing will not occur. If there is an acute ulcers, pain is important. Pain should be controlled. Rest is most important for promote healing. Rest and immobilization. Limb elevation to improve the perfusion, to reduce the edema. Improving the perfusion, reduce the edema. So improve perfusion. Other you may have to give a small dose of aspirin, clopidogrel, if there is a arterial disease. So treating arterial disease is also important. You may have to call vascular surgeon for vascular surgeries and so on, angioplasty or graft or thrombectomy, endarterectomy. Different procedures are there. You can always read my manual. In arterial disease is given detail. Wound debridement, wound toilet is very, very important. So mechanical, different types are there. Mechanical solutions, Visol is there, so many types. But commonly, mechanical debridement by the scissor, you cut the diseased tissue until it bleeds. So dead tissue should be removed. It's very important. Slough should be removed. It's a basic concept. Until it bleeds. Bleeding means there's a live tissue. So live tissue should be allowed to have stay. Dead tissue should be removed so that granulation tissue forms. Then you can cover the defect or close the defect by skin grafting, flap, depending on the situation and your decision. Regular dressing. Usually it's a very good old solution, clear, odorless and non-irritating solution, which is placed in a light blue bottle, and it is Edinburgh University solution. Contains boric acid, calcium hydroxide and bleaching powder. So that removes the slough. Visol bath sometimes will give dilute Visol in a warm water, place it in a bucket, and patient dips his ulcer leg over the solution, dilute solution in the water for 20 to 30 minutes, then do the dressing. That is called Visol bath daily. We used to give that one in the ward. Visol. So full form is available in the ward. Kindly students see how it looks like. So many local applications are available. I'm not going to detail it. You have your own discretion. Cultured maggots may be used today because you know that maggots you apply over the wound. Cultured maggot. It treats only dead tissue, not live tissue. So rather it was a natural debridement. So live tissue will be there. Maggot will not eat dead tissue. Live tissue, it will eat only dead tissue. So one type of debridement occurs using maggots, so not usual maggot, cultured maggots. we use for that. So this is how exactly it looks like vac therapy. See that? Vacuum therapy, negative pressure wound therapy, very, very useful. You connect to the negative pressure section and it continuously sucks this one. So removes all the tissues, removes all the fluid. So infected metal fluid, everything. So it keeps the wound dry. So allows the granulation tissue formation, allows the epithelialization and control the bacterial invasion, reduces the infection. So keeps usually for 5 to 7 days. Canister is here, white color is the negative pressure setup, this one set, and here canister is there. Canister it is called as, and it clears all fluid. So daily you can find out how much it has come. Very, very useful. Currently, very good concept usually most of the places for long chronic ulcers or wounds which is not covering properly. It promotes the wound coverage well in 5 to 7 days. Then you can place a graft without much problem because we got a healthy granulation tissue in the ulcer bed as such. So you saw that is how exactly it looks like. Exenborough unitary solution, clear fluid in a blue bottle. So very commonly used. So full form of USOL is commonly asked at MCQ. Remember, I already told. Then split skin grafting. It's called as Thiersch grafting. THIERSCH. Full thickness graft is called as a wolf graft. WOLFE. So commonly we use Thiersch grafting. So Humby's knife is used. Donor area, commonest donor area is the thigh. Eschman blade or Down's blade is used. So all these names you should remember for MCQ. Viva they will ask. Humby's knife, remember. There is now electrical dermatomes are available, but commonly used with Humby's knife and Eschman blade or Down's blade. Then split skin grafting. It is from the dermis, not from the epidermis. Epidermis and dermis together. And it's a split skin thickness, not full thickness. So donor area heals on its own by epithelialization. Whereas in full thickness, entire skin is removed, but fat should not be placed. And that area has to be sutured on its own by suturing, or you have to put a graft over that if it is a wider area. So that's the full thickness, wolf graft full thickness. Thiersch graft, THIERSCH. Thiersch grafting is the split thickness graft, SSG. We often put short form SSG. So that is commonly used to got stages of skin grafting, stage of plasmatic imbibition. Plasma imbibes uniformly between the recipient bed and donor graft. Plasmatic imbibition and a stage of neovascularization, stage of circulation. So these are 3 stages. Remember, again asked in MCQ, Viva. When ulcer is kept a short case, they will ask what are the stages of graft intake. You have to remember stage of plasmatic imbibition, stage of neovascularization, stage of circulation. So uniform plasma imbibes uniformly between the donor area and recipient donor graft and recipient bed. So remember, trophic ulcer, read my book for all these things. Chilblain, frostbite is the deeper one. This is the superficial. Mortalis ulcer, hypertensive, bilateral in the cough. Pulses are normal. There is a point which is very, very important. Remember, MCQ question it is. Arterial ischemic ulcer, peripheral disease. Barindale ulcer, again, mycobacterium ulcerans, also called as a Buruli ulcer often, if it is a deep and severe. Initially, it is painless, forms a nodule, then gives way. You have to give rifampicin and erythromycin, clarithromycin for treatment. Tuberculous ulcer is undermined. Lupus vulgaris is a type of tuberculous ulcer of the skin specifically. Lupus is wolf-like vulgar it is. So cutaneous tuberculosis, very typical. So word meaning is important. This is a very typical look. Apple gel nodule is Viva question or MCQ question. Apple jelly nodule is seen in lupus vulgaris. This is a point common in face, hand, forearm. You have to give in all these conditions where you think of variant of mycobacteria is as a etiological factor. You have to give anti-tubercular drugs. That's very, very important. But still remember, this may turn into squamous cell carcinoma. Long-standing, untreated lupus vulgaris, in the face it is very common. It causes destruction, very ugly looking, and it may turn into squamous cell carcinoma. That's the point which you have to remember. And remember again, Basin disease, erythrosinus frigida, erythema induratum. Rare it is in both, in girls it is very common in the leg, ankle and ankle region. Maybe tuberculosis is the cause. Tropical ulcer, remember, Fucibacterium fuciform, Vincent organism, Borrelia vincenti. Tropical countries, immunosuppressed individuals, malnourished individuals, common in children. Destruction occurs. Cancrum is one of the type. Noma, it is otherwise called NOMA, otherwise called as cancrum, CANCRUMORIS. Viva question, remember, it is a destruction with the insect bacteria. in immunosuppressant, mainly children with the nutritionally deprived patient in children. And it's often called, say, destruction without proliferation, extensive destruction, bone, everything destroyed, especially in the face. That is called phagoedema, DAENA. Phagoedema, it is not malignancy, FHA, DAENA, phagoedema, it is not phagoedema, it is not malignancy, remember. It is a destruction without proliferation, commonly seen in the concrum worries and tropical ulcers, remember. So phagoedema is MCQ question, short, Viva they will ask, and when you present a short case, they may ask. We should know. So venous ulcer, again, gravitational ulcer, rodent ulcer, BCC, carcinomatous ulcer, Marjolins ulcer, unstable scar of long duration. Well-defined commensal carcinoma, no lymphatic spread. This is often kept as a short case in the exam, remember. Melanotic ulcer is aggressive. Melanotic ulcer. Rodent ulcer is a locally malignant, carcinomatous ulcer loco-regionally malignant. Melanotic ulcer is a systemic disease, remember. So melanoma ulcer, just go through these things, post-operative, progressive, battle synergetic gangrene, commonly seen in the post-operative wounds in the abdomen and chest wall, usually in the abdomen, here, this area, or sometimes in the chest wall, after ampyema, when you treat in an immunosuppressed individual, in the lower abdomen infection, perineal infection spreads upward. After surgery, laparotomy, it may cause all these things. It's a polymicrobial symbiotic infection. Single organism, it will not cause. Microaerophilic streptococcus, it's very important. It's a polymicrobial symbiotic. All these words are important. Polymicrobial symbiotic infection. It's an MCQ question. Begins in the wound margin, progresses deeper, extends to destruction, toxemia, sepsis, may kill the individual. It may cause death, remember. Acute renal failure and acute kidney disease, sepsis, SIRS, and MODS, and mortality may occur. So later, proper wound debridement, later wound coverage, remember, but needs ICU care, and later toxic control. This is the important thing you have to remember. And diabetic foot ulcer, again, you can go through my book, ulcer chapter, it is there in detail. It's very important topic, and main question maybe in the exam. There are so many classifications. The another classification I have discussed as such, common in the foot, very, very common. Commonest entity, maybe one side, maybe other side. Foot complex is involved, bone may be involved, osteomyelitis may be there, destruction may be there, gangrene can occur, ischemia may be there, peripheral pulse may not be felt. So many things participate in that. Neuropathy, ischemia, infection, uncontrolled diabetes if not controlled. These three are the most dangerous triad of diabetic foot. 1, 2, 3. Dangerous triad is the point which is, remember, I told all these things: osteomyelitis, gangrene, ulceration, callosity, corn. Because dryness causes callosity, corn. Fungal infection is very common. Nails, recurrent battle infections, abscess formation, hammer toe, chocolate joint is distracted, joint is lost its control, especially ankle joint. In such a situation, you may have to do amputation, below knee amputation, Burgess amputation you have to do. So all these things are the common thing which happens, very, very difficult to manage, remember. And poor blood sugar control, systemic blood, CKD, cardiac disease, smoking, hypertension, alcohol, which causes the added systemic problem to prevent the healing and promote the destruction of the foot as such. So foot complex got destructed. So that's important things. Major disease actually. So different classifications, you can read my book, it is there. I'm not going to detail that. Maggot Wagner, old University of Texas classification. Amit Jain's, our Indian surgeon, he did extensive work on diabetic abscess and foot. Presented so many papers, and we are proud of him, and had his own classification and approach for the diabetic foot. It's very well accepted universally. That is Amit Jain's classification and management aspect in the diabetic ulcer, including amputation. Pedis classification is very commonly asked question. You can go through my book. And evaluation is important, detailed history and assessment. Systemic is already cardiac, renal, hepatic, neurological, because everything, all system is involved. Blood sugar, HbA1c, very, very important. Urine ketone bodies, again, identify the acute phase and severity. Serum creatine, liver function, C-reactive protein, acute phase, again. X-ray foot or MRI, already told. Tissue destruction, all those things are definitely. Arterial opposite plus scanning, plus B mode scan, brightness mode. Ankle brachial pressure index, less than 0.3 is very crucial. Critical limb ischemia, dynamic CT angiogram, gold standard, already told. blockage, corkscrew repair and distal runoff, collaterals, everything should be assessed properly. ECG echo for systemic assessment, chest X-ray, ultrasound, pus culture sensitivity or tissue culture, that is also important. So treatment is, systemic treatment is important. Call physician, take diabetologist's help rather than you treat on your own, but have a monitor on this patient even though they are treating. Finally, patient is yours. Insulin, cardiac drugs, CKD, nutrition, regular monitoring of the CKD is important. Nephrologist opinion is important. Protein deficiency correction, anemia correction. Infections, repeated infection is very, very important. And perfusion improvement of the limb is important. Local treatment, so systemic treatment, local treatment. So adequate wound debridement under anesthesia, it's very important. Vacuum assisted closure, I already told. Negative pressure wound therapy is a short note. Limited asset dressing, this is the difference between the vacuum therapy and this one. Vacuum therapy is one outlet is there. Negative pressure, I have shown that photo. And whereas in limited access dressing, vacuum therapy is there. One more outlet, one or two more outlet is there where you irrigate. So it's a dry dressing plus wet, intermittent wet dressing. So also you can infuse bacteria locally, not bacteria, sorry, infuse antibiotics locally into the wound. So infuse antibiotic locally, so it to control the bacteria, and irrigate with the warm normal saline, sterile one. Then give a suction. So irrigate, suction. So dry, wet dressing, wet treatment, dry treatment. So alternately. So that is a more asset, more better. That's what they say rather than acute therapy. But both are equally used actually. So this is the vac therapy already I have shown. You add on to put one more portal to create, give wash and antibiotic into the wound. Amigen debridement grading is there. Limb revascularization, maybe thrombectomy, maybe endarterectomy, depending on the CT angiogram. You can do the angioplasty, grafting, or saphenous vein graft, reverse or in situ. So different types are there, different Gracron graft, O1 graft you can use. So different, maybe iliofemoral, maybe aortoiliac, maybe iliopopliteal, like that, different on the where exactly block is there. Then you do a revascularization procedure, take a vascular surgeon's help for that. In spite of that, near 50% of such individuals, because of the improper treatment, rather negligence by the patient, they land with amputation at different levels. So limb salvaging is the priority, but in many situations disease is so extensive, no perfusion. When there is no perfusion, saving the limb is very, very difficult. Remember, that's the most crucial thing. Blood supply is the most crucial thing. If it is not there, they land with amputation at different levels. So read my book, Amputation for Different Levels, especially for diabetic foot. Commonly it's the below toe amputation and the below amputation. Ray amputation, ray, A-R-A-Y, ray amputation, not race, ray amputation, and below knee burgess amputation. This forefoot and Symes amputation will not help because perfusion is not there to the foot. So either ray or below knee amputation or above knee amputation. That's how exactly we do amputation. Mainly remember, all these amputations are commonly done by general surgeons, not by orthopedicians. So you need to know amputation in detail properly. So precautions are avoid injury, care of feet, diet control, circulation improving drugs, regular monitoring, MCR chappal, microcell rubber chappal to pressure over the pressure area to prevent, because autonomic neuropathy causes the problem. Regular follow-up. Factors affecting ulcer healing. This is not diabetic in general. These are the local factors, are the general factors. For wound healing also same, for ulcer healing also same. I'm not going to detail it. See these things: age, obesity, smoking, vitamins very important, deficiency. So correct it. Hypoxia, malignancy, uremia, steroid patient, steroid therapy, neuropathies, mainly neuropathy in the diabetic patient. All these local factors, necrotic material, hereditary area, wound, joint area, remember. So this table helps. It's a commonly asked question, short note. Enumerate local factors, enumerate general factors, systemic factors. Just remember the names so you can have the idea and correlate and right answer. So it is the active ulcer, see that, this is the undermined ulcer, trophic ulcer, this is the healing ulcer, the deep ulcer with the osteomyelitis. See that this is the maybe malignant ulcer or severe necrosis. So all those different ulcers, just have a photographic picturization of these ulcers so you can express properly. So this is the osteomyelite, severe osteomyelite destruction. So many metatarsal and phalanges have destructed, see that. So that is very typical of X-ray. Now we can do MRI. So that is in brief about the management of ulcers. It's a very vast subject. read my manual of surgery, ulcer topic. It's a very detailed thing, but if you remember this one, you can express in short case, exam, theory. Also, you can develop from that. You can develop and recapitulate from my book and write the proper answers. You can express on MCQs also. So read my manual of surgery for ulcer. Read my clinical method of surgery for ulcer examination. And for operative procedure, you can read my surgical SRB surgical operation test and atlas. The current edition, new edition is there. It is extensive detail about the skin grafting, flap, and different approaches of wound abridgment, everything. And also again request all students to go through my website, SRB Surgery Insight YouTube channel. Subscribe and share with your friends and colleagues for daily updated MCQs or brief lectures or long lectures, and live sessions once in 2 weeks where student will present case and 1.5 hour interactive discussion about the case presentation and how to go ahead with the management with not only me and other faculties like senior faculty from different colleges will join, so that you can interact and learn proper way, and also you get a certificate for joining the live session. And daily go through my website, daily lectures. I have learned daily lectures and MCQs which is coming in the YouTube, which is free. Subscribe, learn for 5 to 10 minutes daily, and weekly long lectures, and also live sessions once in 2 weeks, so that update your surgical knowledge. And always please go through my manual of surgery. It is covered everything as per CBM syllabus: general surgery, gastrosurgery, specialties, endocrine, and instruments, anesthesia, all other things. Covered everything with the treatment, illustrations, photos, footnotes, lot of diagrams. We covered everything with for each chapter online MCQs are there, and extra points are there in the online, so that even NEET exam or competitive exam you can write with these online MCQs. So I have my manual of surgery. It's more than sufficient to learn surgery for PGs and UGs and face any exam. My clinical method in surgery, with each chapter having examination video with the QR code, and you can hernia, general examination, thyroid, breast, abdomen examination, urology examination, swelling, ulcer, arterial disease, venous disease, briefly orthopedic with the instrument and specimens. Detailed methodical exam, lot of photos are there with the differential in a tabular form. But there is no management because it's a clinical book. But it's the best book, both clinical method and manual surgery. Please purchase this book and learn surgery, and go through my operative surgery to learn surgical steps properly. And always subscribe my YouTube channel to have a surgery daily learning process as such. Students, also my DigiNow lectures through JP Publishers is there. 220 hours lectures, covers everything, general to basic to gastro to urology, cardiothoracic, neurosurgery, basic, instrument, specimen, clinical exams, everything it is covered. And you can purchase for 1 year and learn my all lectures. In that, in detail lectures are there. Everything is covered for your syllabus, specialties, everything. It will be useful for UG and PG also. So please purchase that one, subscribe that one also. It's paying question. So again, students, I hope you have understood this brief lecture on ulcer management. It's a very, very important topic. Very well. Thank you so much.